All right, y'all, this is our 9th and final myth about urinary tract infections for this video series. Do Foley catheters put patients at disproportionate risk for infectious morbidity in the hospital? That's certainly what we learn. We previously talked about how specific symptoms attributable to the urinary tract are a prerequisite for treatment of bugs that grow on urine cultures. There is no difference in hard outcomes in antibiotics versus placebo in patients outside of symptom reduction. Antibiotics do not prevent pyelo, do not prevent acute kidney injury, do not prevent chronic kidney disease. So symptom assessment is key to weighing benefit of antibiotics over the harm that they cause. The problem is that as soon as you throw a Foley catheter in a patient, any sort of symptom assessment becomes unreliable. Yes, patients with Foleys have higher mean temperatures and higher peak urinary white blood cell counts, but I don't think that these differences are actually clinically meaningful at the bedside in a patient with a fever. Patients may complain of dysuria, hesitancy, and frequency, our pillars of UTI symptoms, just from the plastic of the Foley going through their urethra. Especially when a Foley comes out, that irritation can remain for 48 hours, and you can have pseudo-UTI symptoms that persist. Foleys are not comfortable, it turns out. To add insult to injury, Foleys predisposed to bacteriuria is inevitable. At a cumulative rate of about 7% per day, almost all catheters will become colonized by 2 weeks. Despite this eventual colonization, most cases are asymptomatic, and there is no difference in the group with bacteriuria and without bacteriuria. Thankfully, ascending disease, pyelonephritis, and bacteremia is extremely rare, happening less than 1% of the time. In patients with chronic Foleys, almost all are colonized. 3/4 are polymicrobial, and bacteria seem to rotate in and out about every 2 weeks. Gram-positive cocci typically last around 1 week and then switch out. Gram-negative rods last about 6 weeks. This is even despite meticulous urinary bundle care and cleaning the patient's perineum. Trying to keep a crotch sterile is an exercise in futility. Give me a patient incontinent of stool and even more so. But remember, colonization with bacteria does not equal infection or require intervention unless there are symptoms attributable to the urinary tract. Unfortunately, what we still see is reflex blood cultures, chest x-ray, and urine culture in patients with any sort of decompensation, new fever, new white blood cell count, increase in pressors, etc. Urine positivity is such a frequent red herring that ICU guidelines have recommended against assessment of the urine in newly febrile patients. It's only going to obscure your diagnosis unless your pretest probability is higher, like in patients with urinary tract obstruction, recent urologic surgery, etc. Could Foley-associated bacteria cause ascending infection and decompensation? Sure, but remember, this is rare. It happens less than 1% of the time. There are a lot of other things in the ICU that can cause decompensation that happen more than 1% of the time that we don't routinely order. But checking urine is easy, and when positive, creates confirmation bias that makes us feel like we know the answer to why a patient got sick. In a trauma patient population, where Foleys are highly utilized, there was no association between positive cultures and fever or white count. The conclusion of this study was that urine cultures were low yield in their ICU setting when ordered in response to fever and leukocytosis. So let's use that surgical population, for instance. Let's say that fever attributed to the urinary tract happens 10% of the time in post-op patients. Let's say that urine cultures in patients with Foleys had a good positive likelihood ratio. They don't, but let's say it's good, like 10. This would be like a scenario where bacteriuria, when it was present, always represented infection and the cause of fever. The likelihood ratio changes the pre-test probability into the post-test probability. And in this scenario, we see that our post-test probability got a significant boost, making urine cultures a useful test to order. But we know that this scenario isn't in fact true, and that urine cultures can be positive in patients with and without fever. So the true ratio is probably much smaller than 10. Let's say it's at like 2. Even with a positive culture, it doesn't actually tell you that the patient is sick because of the positive culture. You're just defining the normal state of things. It's important to remember as well that the risks for underdiagnosing UTI in catheterized patients is very small. We've showed this less than 1% of the time they're going to ascend. The risk of overtreatment and even missing the true cause of the fever can actually be a lot higher than that. All of this is to say that urine cultures are unreliable in patients with Foleys, and we really shouldn't be sending them. If they are sent, we should be skeptical of them, unless our pre-test probability is high enough that our bad test, the urine culture, affects our assessment after it comes back positive. A good way to avoid Foley-associated bacteriuria is to avoid placing a Foley in the first place. I think that catheter reduction is still a viable target in the hospital. There is the perception out there that IO caths, as an option, increase the chance of urinary tract infection compared with Foley. This is, I guess, a sub-myth. Data actually suggests that serial in and out catheterizations have a much lower risk than anchoring a Foley. Using IO caths in patients with transient obstruction should probably be the standard of care as opposed to just automatically anchoring a Foley. I learned in medical school that Foley catheters put patients at risk for hospital mortality, and the lie detector said that that was actually a lie. I mean, don't get me wrong, we should try and reduce Foley utilization, but if you need one, you need one. It's just important to know that your patient is going to become bacteriuric with the device in place. Thankfully, these colonization events rarely lead to ascending infection. If you're worried about colonization, don't use Foleys. IO caths may be a better option, next dwelling devices, or something else that you can use. In general, urine cultures from catheters do not help distinguish a disease state from a non-disease state. Antibiotics can create resistance in biofilm-forming bacteria, and severe infections associated with Foley catheters are thankfully rare. This was the 9th in a series of lectures that you can find at our Viper YouTube channel. Take a listen to our other 9 myths about urinary tract infection that get mistaught in medical school. Let me know if you have questions.